present today is the moderator, Dr. Fathia, and give it to you. You can take it from here. Thank you.
Thank you so much, Dr. Nader. Thank you. Yes, I'll be moderating for the pink team today, and we have 4 topics that we'll be covering. So I'm going to go ahead and start with topic number 1, which is the cardiovascular disease in older people. Let me just share my screen real quick here. Alrighty. And I hope everybody can see my screen.
Yes, you can.
Awesome, perfect. All right, so I'm going to go ahead and dig into it right away. So we're all aware of the fact that cardiovascular disease is the leading cause of death in the US and worldwide. It affects more older individuals than the younger ones. At autopsy, they found out that 50% of elderly women and 75% of elderly men, they have obstructive coronary artery diseases. And with the people who are over 80 years old, which is the octogenarians, they're like 80 to 89, which they comprise about 5% of the US population. But it turns out that 20% of the cause of hospitalizations for those individuals is actually MI. And the older it gets, the worse it gets, basically, for those individuals. The clinical manifestations for coronary artery disease or heart disease in general, they vary. The symptoms of typical angina, as we know it, the chest pain, it only happens in 40% of individuals. But the others, they could present with symptoms such as dyspnea, nausea, vomiting, syncope. Some of them might be admitted in the hospital for pneumonia, so they get post-pneumonia symptoms, and then they get secondary MI. Also, if they were just in the hospital for a fractured hip, they could also develop MI as well. Some people, they present with flash pulmonary edema right away, and the symptoms vary depending on the person and individual, of course. People with comorbid conditions such as diabetes, hypertension, they might have more of a silent symptoms, and they don't get to the cause of it until actually developed and more severe. The mortality rate in those individuals actually is increased, as I said, due to comorbid conditions, if they have more extensive coronary heart disease, and they usually have like a lesser use of beneficial therapies. So when we do go ahead and compare treatment, depending on the age of the patients, it's divided into 2, people who are over 75, people who are under 75 years of age. So in terms of thrombolysis, it turns out that people who are over 75 is only useful in 5% versus 39% if you're under 75. Same as with the catheters, it's 7% if you're over 75 versus 29% if you're under 75. If you go to a cabbage, it's 5% only if you're over 75 and 11% if you're under 75. And with aspirin, it's 57% if you're over 75 and 82% under 75. So basically, the older you get, even the medications, they don't really work as well. So you get more complications, less use of the therapy that you'll be going under. The people who are in their 80s, actually with unstable angina, they're treated medically. They have an event-free 1-year survival of only 55%. So the other 45%, they might develop some complications during the first year post the incident. The stenting outcomes are similar in the older versus the younger groups, although some studies do show some excess non-Q wave MI and vascular complication, but they're not as common. So overall, we'll just say they're almost similar in terms of stenting. When it comes to the cabbage procedure, the 3-year survival is 77% versus 54% with medical therapy alone. And when it comes to the 5-year survival in cabbage versus stenting, is 66% versus 55%. So if it's like stenting versus cabbage, it's always go with the cabbage. And also the people who are in their 80s, there is a 4.7% mortality rate, but unfortunately their hospital course is usually super prolonged and very complicated. We'll talk about the risk factors when it comes to heart disease. The most common risk factors are the top 3, of course, are smoking, hypertension, and hyperlipidemia. Those are the top 3. So we're gonna go ahead and start with number 1, which is smoking. So what's the problem? What's wrong with smoking? Smoking usually gets to increase blood pressure, increase your heart rate. It will increase the pulmonary vein resistance. It will increase your catecholamines, so you'll always be in the flight-fight mode. It will increase the susceptibility to clotting, and it will decrease the HDL, which is the good cholesterol that we have. The problem with smoking actually is not a problem, but if you do stop smoking, the smoking cessation, it would reduce the mortality rate by 25 to 50%. So which is a very huge deal. The intervention that we need to do as physicians is whenever a patient comes to the office and we do know that they have a problem with smoking or they have smoked in the past or anything like that, we need to advise them to stop smoking, get them into any kind of support groups as much as possible. There are pharmacological therapies, a lot of drugs that can discourage the patients from smoking. Also, we need to do a telephone follow-up. In the practice where I work, actually, we do have, it's a position called a case manager. The only job for that individual is just to make phone calls, post-hospital discharges, post-office visits. They basically just keep calling the patients every day to make sure they're actually doing what they're supposed to be doing. Because as all older people, they just, it's not like they don't listen, but they forget a lot. They don't stay on track. So we just need to remind them basically. Also, nicotine replacements are very safe. They can be found in any store right now, so they're super affordable. And cardiac rehab programs. They provide a lot of counseling, and every patient who's ever had an angina or MI or any kind of cardiac procedure, they usually undergo cardiac rehab right afterwards. They teach them a lot of stuff about their medications, how to take them, exercise, but also they get a lot of counseling as well on all the risk factors that they can avoid. The second risk factor, as we mentioned, is hypertension. Sadly, more than 60% of adults over the age of 60, they do have hypertension. And the ones who do not have hypertension, they do have a 90% risk of developing hypertension anytime in their lifetime. So it's unavoidable, basically. So the best thing we can do is to manage it properly. The isolated systolic hypertension, that's the most common in this age group, which is from the 55 to 65. 60 to 75% of the cases, it happens to them, and it's probably due to diminished arterial compliance, which just happens with age. Those individuals, they have threefold increase in the risk of MI, left ventricular hypertrophy, renal dysfunction, strokes, and cardiovascular mortality as well. The isolated systolic hypertension, it increases the risk of coronary artery diseases and heart failure and all the heart disease in general. The risk actually varies directly with the systolic and the pulse pressure, and inversely with the diastolic pressure. So basically, the higher your systolic is, the more you are at risk of developing CAD, and the lower the diastolic pressure is, the higher you are to develop the CAD. And the worst outcomes that we've seen in elderly are the people who have low diastolic pressure, like very low diastolic pressure. And the reason is because basically the heart gets all this nutrition, the blood supply, everything during diastole. So if it's super low to the point where it's like below the level needed to maintain perfusion, then we're actually harming the patient in a different way. So the goal should always be 65 or less in the patients who have CAD, and the minimum should be 60 in the patients who do not have CAD. So we do not need to drop the diastolic blood pressure lower than that, because it would be just harming the patient. In terms of the treatment for hypertension, we always start by non-pharmacological treatments, obviously. So we start by sodium restriction, exercise, treating obesity if the patient is overweight, they need to cut down their calories, all of that stuff. And then we'll go on and jump into the drugs that we actually do use. So in terms of sodium restriction, the usual diet for individuals is about 4 grams per day. But if you're a patient with CAD or heart failure or any heart disease, the recommendation is to cut that in half. So it's only 2 grams, which is 1 tablespoon of salt per day, and that's it. There was a study, it's called the TONE trial, which is a trial of non-pharmacological intervention in the elderly, where they got people from the age of 60 to 80, and they divided them into 4 groups. The 4 groups were like 1 group for just weight loss diet, 2nd group for salt restriction, 3rd group for both weight loss and salt restriction, and the 4th group were just the control. They're just living their life as they normally do. And they found out with the intervention groups, all 3 of them, the patients, they dropped their blood pressure 2 to 4 millimeter mercury systolic, and 1 to 2 millimeter mercury diastolic, which might not seem that significant, but it's also very important. And it's not just the salt in those people, because the more salt they have, the more water they retain, the more that's burden on the heart to actually keep pumping. So even though it's not that significant of blood pressure reduction, but it's still recommended to advise the patients every single time they come in to reduce their salt intake and to exercise and do the other non-pharmacological advantages, basically. Also, they did another study where they found that it was 15,693 patients over the age of 60. They all had systolic hypertension, and they checked the number needed to treat to prevent one major cardiovascular event. And it was 18 men and 38 women. It was 19 for the people over the age of 70, 39 individuals under the age of 70, 16 in case of prior cardiovascular diseases, and 37 in the people who do not have cardiovascular diseases. There was another trial that was done, which is called the SHAPE trial as well. In that trial, they had people who had high blood pressure. So put some people with therapy, the other people were just on placebo. So the ones who were put on therapy or any antihypertensive drugs, they achieved a blood pressure of 143/68. The ones who were just on a placebo, they were at 155/72. So definitely medications do work significantly, a lot more than the non-pharmacological advances. In terms of stroke, it was dropped by 5.5. It was only 5.5 in the treated individuals. It was 8.2% in the placebo individuals. And there were also 1/4 decrease in cardiac events and reduced left ventricular mass index as well. So basically the takeaway is medications do work far more than anything else. The other trial that was done, which is the HIVE trial, that was done in the very older individuals, people who are over 80 years old. They had 3,800 patients. They put some on just placebo, and the other ones were put on indapamide and perindopril, both medications. And the results were, in terms of fatal stroke, there was a drop by 6.5% in the placebo group and 10% in the people who were medicated. And the deaths from all cause, it was 47.2% in the placebo, but it was dropped by 59.6% in the people who took medications. And the goal blood pressure in patients over 80 should always be 150/80. Like, we do not need to drop it below than that. And the people who are less than 80, yes, we can go up to like 140/80 perhaps. But if the patient is over 80 years old, 150 systolic is perfectly fine for them. So whenever we want to manage the hypertension or high blood pressure in patients, the idea is choosing the right drug. We do have a bunch of medications, a lot of groups that we can choose from. But the facts are, we have to start very slow and then we titrate up. And we need to remember that the bioreceptors, they do not work as well in the patients who are older. So even if you want to stop the medications, we need to taper down. We cannot just stop them like right away. The other thing that we need to keep in mind is all people who are older, they do get orthostatic with or without medications, regardless. They tend to get orthostatic. So it's basically you're weighing the benefit versus the risk in those kind of individuals. Do they really need the blood pressure medication or do they not? Do they have support or do they not? So it's like a judgment based, basically. The medication that we can choose from, we do have the ACE inhibitors, we have our CCBs, we have our ARBs, the renin inhibitors, the central alpha agonists, alpha blockers, beta blockers. They all depend on the comorbidities, the type of patient that we're dealing with, if they have any high blood pressure, only if they have like high blood pressure with diabetes, high blood pressure with heart failure, they have high blood pressure with asthma. So it depends on if they have renal failure. So we have a wide variety of medications that we can choose from. We need to bear in mind also that most elderly will require combination therapy, so they do not benefit much on monotherapy. Also, if the patient is taking a lot of drugs, you don't want to, basically polypharmacy is a problem with the elderly. So we don't want to give them like 2 different medications for hypertension. What we can do is we can use a lot of combination therapies out there. So we can just give them a combination therapy. So it's just one pill and they got to take once a day and just call it a day and that's it. The other thing is we should always avoid beta blockers as a first-line treatment unless it's indicated. Beta blockers, they tend to cause a lot of bradycardia in those individuals, a lot of hypotension. They might get extra orthostatic. So if it's not super needed, then we just need to avoid it altogether, or it can be used as an add-on, but not as a first-line treatment. We also need to consider the cost for those individuals because as we all know, elder people, they usually depend on the like social security and stuff. So they cannot afford the like high brands or high expensive medications. So we need to keep it generic and also low cost medications. It will go a long way. So as we said, we need to do a combination therapy. So the idea of the combination therapy, as we just said, basically it's best if we just use a combination therapy, once a day dosing. So they don't have a lot of medications to use. They get usually a greater response more than the monotherapy. It has fewer side effects, fewer metabolic side effects. And also they do tend to cost a lot less than having 2 different medications to be on. Some of the combinations that we do have out there are amlodipine, benazopril. This combination is called Lotril. That's the other name for it. We also have lisinopril with hydrochlorothiazide. They do have several different names of this one as well. So those are 2 combinations that are most commonly being used in this population. The other additions that we could use are diuretic, but they're not super, they're not the best to be used in the patients who are over 80, I would recommend, because nobody who's over 80 can afford to go to the bathroom every 3 hours. So if we didn't have to use them, we better not use them, but it's an option out there. Diuretics, and also we could use calcium channel blockers. The further addition that we could use is the aliskiren, which is renin inhibitor. It goes by Tecturna. It's still only made by like 1 company so far, but it's super expensive. So we don't really go for that one unless we really need to. The other medications are like beta blockers, our central alpha agonists, and the peripheral alpha blockers, which are used a lot by the patients who are elderly, especially in men. So just to summarize and just to recap all the risk factors in the elderly in terms of hypertension. So among the elderly who are less than 80 years old, we need to initiate therapy when the systolic pressure is more than 140 and their diastolic is more than 90. If it's at 140 over 90, we just keep it as it is. The individuals who are over 80 years old with isolated systolic hypertension, we only need to start medication if they're over 50, over 150. If the systolic is over 150, we can start medication. If it's at 150, we keep it as is because it does not need to drop more than that. Also, we need to pay attention to diastolic blood pressure. It cannot drop more than 60. Otherwise, we'll be harming our patients as well. And that was the second risk factor. So far we covered our first risk factor, which was smoking. The second risk factor was hypertension. The third risk factor is hyperlipidemia. So the total cholesterol levels usually tend to increase with age, primarily from an increase in the LDL cholesterol, which is our bad cholesterol. And that just happens with aging for all individuals. And multiple studies have shown that high LDL and low HDL in the elderly is associated with significant coronary heart disease risk. So basically what we need to do is just reverse it. What we need to do is work on the LDL to drop it and increase our HDL. In terms of management, the benefits of lipid-lowering drugs in the elderly. So they did about a lot of trials. We have about 5 of them here. There was the 4S trial, which is the Scandinavian trial. They tried simvastatin in 1,000 patients over the age of 65. All of them, they had angina or prior MI. And the treatment can reduce all-cause mortality by 34%, which is huge. The mortality from MI was reduced by 43%. And the need for revascularization was reduced by 41%. And these are amazing numbers. There were some other trials, the CARE trial, there's a lipid trial, there's also a PROSPER trial and a SAFE trial. And all the trials, they just basically use a different statin. They use like atorvastatin in one, pravastatin in one, simvastatin another one. So all kinds of statins, they do work. And the idea is basically whenever you want to start the patient on medications, we start by the first one, which is atorvastatin, known by everybody else. If they do have complications from that medication, we just move them to another medication, pravastatin or simvastatin or whatever, but any kind of statin would work and recommended for all older individuals. There is a misconception that's going around that lipid-lowering drugs, they do take a very long time to work, so there's no point of using them. But in reality, they do work in about 6 months. But there was a study that proved that there was endothelial dysfunction improvement that occurred in mere few days. So they should definitely be used. In terms of side effects, some people suggested that the elder individuals, they do have more side effects than the younger ones, but that's absolutely not true. They do have similar side effects in terms of like myopathy, elevated liver enzymes, and so on. So if they do have complication from one drug, it doesn't mean they have to stop all kind of statins. They just move on to a different kind, lower dosing, but they should be on some sort of statin. In terms of cost, it's not an issue with generics. If you use just a generic atorvastatin, you do not go for brands. It should not be very costly and it's very affordable. There was a topic about primary prevention. So primary prevention, basically in the individuals who they do not have high lipids, they do not have high cholesterol, the lipid profile is top notch, no problem whatsoever, but they could also benefit from the use of lipid lowering drugs as well from statins. So it turns out that more than 40% of those individuals who are over 65, they do meet the NCEP guidelines for treatment, which is the National Cholesterol Education Program. They recommend that more than 40%, they could use it, and it will be very beneficial for them. Also, it turns out that 37% incidence of subclinical vascular disease in patients over 65, they just didn't feel it because it was subclinical. And they found out by measuring their EKGs, by their echoes, by the AAI, which is the same as ABI, the ankle brachial index, especially if it was less than 0.9 as well. And the more than 50% of elderly people, they will die from CAD. Also, there was a cardiovascular health study. They studied the individuals who are over the age of 65. They do not have any heart disease whatsoever, but they also benefit significantly from the primary prevention and using a statin. So they definitely should be recommended and should be used in anybody who's over the age of 65, regardless if they do have a risk or not from developing heart disease. The other management that we could use, so we need to address the side effects, obviously, and address the risk factors, which are like smoking, hypertension, and high cholesterol. But also, there is a recommendation that aspirin should be used, and the elderly who they do have CAD. And if we do use aspirin, we need to combine that with a PPI. We don't need them to get gastric ulcer or anything like that, except if you're using clopidogrel at the same time. Then if you are using clopidogrel, then you should not be using a PPI. Because PPI will just make the clopidogrel kind of ineffective or will slow the actual action of the clopidogrel. And then the patient might stroke out, even though you feel like, oh, he's on clopidogrel, so they are protected, and they're really not. So use aspirin combined with PPI unless you're using clopidogrel as well. And the aspirin in primary prevention in men have already been proven, but in women it's still kind of controversial. So we need to weigh the risk benefit, obviously. Just do bear in mind that most studies that are being done right now, or a lot of them, the older studies per se, they're done on like white Caucasians. So not a lot of studies that are done on women, but they're still being recommended for them as well, regardless of this being controversial or not. The other medication that we do put the patients on are ACE inhibitors and beta blockers for any patient who had MI upon discharge. They usually put them on the aspirin, clopidogrel. We put them on the statin, as we mentioned. Also, we give them some ACE inhibitors and beta blockers once they're good and stable and about to be discharged from the hospital. The other thing that we need to also do is exercise. Well, the American Heart Association right now recommends about 150 minutes of moderate intensity exercise per week. But if you're doing like a vigorous exercise like kickboxing and whatnot, then it could go down to 75 minutes, but everybody has to exercise a certain amount of minutes per week. And the benefits of exercise are it improves the exercise tolerance, it will reduce the symptoms, there will be a lot of reduction on the cholesterol levels, there'll be a reduction in the cigarette smoking as well, it will improve the psychosocial well-being of the individuals, it will lower the patient's blood pressure as well. So there are like countless benefits of doing exercise as well. The barriers, I wouldn't say there's any, but if the patient is now on treatment, they could be having like, socioeconomic status is very low. They don't have access to gyms. It might be expensive to get the gym membership, but one could also try just walk on the street or something that would also be beneficial. It's better than doing nothing, basically. The diagnosis that they qualify for filling in cardiac rehab or any cardiac rehab in general. Usually any patient who had heart attack, atherosclerotic heart disease, angina, they had an abnormal stress test. If they have any valvular heart disease, they just got implanted with a pacemaker or an ICD. If the patient has heart failure, they had an angioplasty or atherectomy. If the patient had a CABG procedure, heart transplant, any of those individuals, they could definitely benefit from a cardiac rehab, which is always recommended right after discharge. Once they go to cardiac rehab, they basically teach them how to go back to their previous life, how to manage their symptoms, to do a few exercises, some counseling. It's very beneficial for patients who cause any cardiac event, I would say. There is a few slides that we're gonna touch on just very, very briefly. It's about AFib. The topic of AFib is very, very common in the older individuals and has a lot of reasons due to hypertension, people who have sleep apnea, obesity. All those reasons are, people get AFib from it as well. If the patient is older, more than 65, more than 75 years of age, and they have AFib, we kind of manage it based on symptoms, basically. So if they are symptomatic from the AFib, they may need to be cardioverted. Either we give them amiodarone, cardioverted by shock, whatever, but they have to be cardioverted. If they do not have any symptoms, it's better to stick to a rate control maybe. So we just give them basically any CCB just to control the rate. If they're anything below 90, it's perfectly fine. They can live with AFib forever. But the thing is, they need to be put on anticoagulant because based on our CHA2DS2-VASc score, anybody above the age of 75, they're already 2+. So they need to be put on anticoagulant. And most cardiologists out there, they do put the patients on warfarin just because they're so used to it and it beats everything else. But the problem with warfarin is it needs to be monitored by INR. The patient, they tend to fall a lot in the elderly, and then they get a lot of bruising. They might get a lot of ecchymosis, and there's a risk of comorbidity as well. So maybe if we do stop the warfarin and we tend to go for something else, maybe they should be put on aspirin or clopidogrel, or maybe any of the new oral anticoagulant, the Eliquis and Xarelto and all those medications. They might be more beneficial. And by that, we do conclude our presentation for the cardiovascular disease in the elderly. Let me just, I'm not the best tech savvy out here, you guys, so it usually tends to take me a minute to share and share and do all that kind of stuff, so just bear with me. All right, so I'm gonna go ahead and stop sharing my screen. And we do have the next topic that will be presented by Dr. Rowan, and she'll talk about IRB and how we do it and everything that's entailed in it. So Rowan, if you're here, you can go ahead and start. And if Dr. Radi has any few comments, go ahead as well. All right. Rowan, you're still on mute.
Hi everybody. I am Rowan Ahmed, and I'll be talking about the next topic, which is the IRB. It stands for the Institutional Review Board, which is a committee that ensures the ethical treatment of human subjects in behavioral science research. So that said, so here, these slides were done by the faculty seminar dean, Owen, and he has a disclaimer here. He said that he claims not to be an expert in the field of biomedical or behavioral science research ethics. And additional warnings here that prolonged contact with skin should be avoided, not to be taken internally. No animals were harmed during the production of this presentation. And of course, that science has one goal. It seeks knowledge and truth, but the research must be governed by rules of conduct and basic ethical standards. So this is said especially when our fellow human beings are being researched on, and this is the reason for the IRB. So what are we going to cover in these slides? Why an IRB, and what led to the IRB? So I'm going to talk about some history in the human research, how they experimented on the bodies, on human bodies. And of course, I'm going to talk about the basic principles of research ethics and the role of the IRB and its function. So a brief walk through history in human subjects. So it's said that like years ago, before Common Era, BCE, two people, Herophilus, who is said to be the father of anatomy, performed vivisections, like operations on human beings, living human beings, on more than 600 prisoners. And another person, Claudius, he also, years before BCE, he performed many experimental procedures on wounded gladiators from the Roman games, and is regarded by many as the father of modern medicine. So these two people experimented on human beings a long time ago. And another person, Irishmen, William Burke and William Hare, in the early 1800s. He also became infamous for grave robbing business as a method to provide fresh cadavers to Edinburgh anatomy schools. So these people researched on human bodies. But more recently, starting from the 1911 to 1979, a person by the name of Dr. Joseph Mengele, he was a physician and a German officer in the Nazi concentration camp, Auschwitz, performed also hundreds of vivisections on prisoners. It was human abuse. So he experimented on these people doing operations without anesthesia, injecting chemicals to change the eye colors of some of the humans. And also, I think he also experimented how long will it take for a 70-kilogram male to die when submerged in a tank of ice water. After that, here in America, in 1932, you probably heard of the series of research abuses in Tuskegee, Alabama, the syphilis research. It was done on poor Black males who had syphilis, and they wanted to experiment the natural history of syphilis on these people without giving them treatment. Even after the penicillin came out in 1947, they didn't give it to them since penicillin is a treatment for syphilis. So the abuses were revealed in 1972. And at that time also, meanwhile, in 1947, 26 Nazi physicians were put on trial at the Nuremberg, Germany, for research also atrocities. So they violated human bodies. They performed on prisoners of war. And this resulted in the Nuremberg Code, which was the first internationally recognized code of research ethics issued by the Nazi War Crimes Tribunal. And this code included the principles of informed consent, absence of coercion, so and properly formulated scientific experimentation, beneficence toward experiment participants. So they had to come up with a code that stopped human abuse And these are the principles included in this code. After 1947 came 1964 in Finland, Helsinki. They issued recommendations to guide physicians in biomedical research involving human subjects, and that was under the title of the Declaration of Helsinki, and it became the basis for later boards of ethics and self-regulation by researchers. Then came in 1974 in the United States, the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research was established, and the National Research Act is passed by the US Congress. So in 1974, the National Research Act prompted the establishment of institutional review boards. This is where it came, and it required IRB review for all federally funded research with human subjects. So the IRB reviewed all the researches about humans. And in 1979, after that, the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research published the Belmont Report, which is about the ethical principles and guidelines for the protection of human subjects of research, a guide for US research with human subjects. So that to be said, the Belmont Report, which is about the basic principles of ethical research with human subjects, included all these three principles, starting with autonomy, which includes that each person should be given the respect, time, and opportunity necessary to make his or her own decisions. So it's, they have to make their own decisions. They have to be respected. And then number 2 principle is beneficence, that obligates the researcher to secure the well-being of all subject study participants. It's the researcher responsibility to protect participants from harm, as well as ensure that they experience the possible benefits of involvement. So it goes 2 ways. And then the 3rd principle of the Belmont Report is the justice. Participants should not be selected due to class, socioeconomic status, or race unless justified by study objectives. So all research conducted in the United States that involves human subjects, living or deceased, human tissue, records gathered should be reviewed. Records gathered on human subjects. So all 3 of these. And regarding training of all these researchers from colleagues and universities, they must complete a training program on research ethics before submitting a research proposal for IRB review. And this training emphasized on informed consent, which is very important. The informed consent is not about signing a form. It's about an individual's understanding and willingness to participate in a study. So each subject should understand very well what the research is about before deciding on it. And the potential participants must understand, and that is probably in the informed consent. They should know the purpose of the study, the procedures to be done on them used in the study, the potential risks and benefits of their involvements, and alternatives to participation. If they don't want to participate, there should be alternatives that should be communicated by the researchers, and they decide upon it. So these are all parts of the process of the IRB. And the most important part of this process is to discuss any question or concern with a knowledgeable research team member, and in addition to that, a potential participant must be given time to think about their decision and discuss it necessary with family, friends, or religious advisors. So this is like a chart, a flow chart of an example of a consent process. First of all, a study's population profile should be identified, should formulate a consent document according to the IRB guidelines. So you shouldn't just go ahead and just write a consent document. You should do it according to the guidelines of the IRB. Then it goes on to obtain approval from IRB. So after that, after the consent document is formulated, you apply to the IRB, and they should either give you an approval or not. And then after that, present and discuss with the participant and make sure that they can withdraw at any time from the study, answer the participant questions, give participant a copy of consent document, allow participant to consider participation, meet with participant to assess understanding and answer questions, obtain appropriate consent, and then start the research. So the institution review board, there's a membership to it, and it composes of at least 7 members, but the size can vary. Members are usually elected by their colleagues according to their research experience and seniority. Members have typically undergone extensive additional training by medical and behavioral research ethics. So they should be experts. Typically serve in a consultative, educative and voluntary capacity. And there's a criteria for the IRB review. Again, that the research should abide to it. First of all, risks to subjects should be minimized. So the risks to subjects are reasonable in relation to anticipated benefits, and selection of subjects should be fair and equal. And then comes the informed consent, which should be sought from each prospective participant or his or her legally authorized representative and properly documented. Adequate preparation is taken to protect the privacy and confidentiality of subjects. Then adequate provisions are made for the ongoing monitoring of subjects' welfare. They should be monitored for any risks along the trial, the clinical trial. And then goes on. These are like questions about to fulfill the criteria for the IRB review. Again, is there any adequate provision for an informed consent process? Has it been adequately provided? Is the study adequately described in a common language? They should be able to understand it. I think the language that should be communicated here, I think it's maybe high school level. I'm not sure. Like as long as everyone knows until that level. Are the benefits and risks clearly stated in the informed consent as well? Are alternatives to participation clearly stated, as I mentioned before? Is there adequate opportunity for consideration and discussion? Is there some mechanism to ensure that subjects understand? Are there provisions for special categories of subjects? So this is the IRB review job, as well as the informed consent, just to make sure that everybody is safe and protected. And then comes the IRB process. After all of, before this is done, so the researcher plans his or her research, and before conducting it, they have to submit a formal application for review through the IRB, and then the IRB assigns the proposal to one of these following categories. Either the proposal, when reviewed by the IRB, goes under exempt or expedited, or under full review, including all the risk and informed consent. It is the IRB's responsibility to determine into which category the proposal goes, and all research proposals must be reviewed. Following that review, the IRB will issue approval, and only then may the research project begin, after it either have fallen under exempt, expedited, or full review. We're going to talk about the risks. So the risks to subjects in behavioral science research. The risk may involve physical stress. That means either elevation in heart rate, respiratory rate, blood pressure, or electrostimulation, or it may introduce psychological stress in the form of uncertainty, doubt, anxiety, depression, anger, humiliation, ridicule, or the research may involve invasions of privacy or measures of sensitive information in which subjects might be identified through audio video tapes of abuse descriptions, surveys of sexual behavior, prior or current drug use, or other legal behavior. So going back to the categories of the IRB review, the first category, when they get the proposal and they review it, it might pass into exempt, where there is no risk. So the research here, it poses no significant risk to participants, and it is conducted within the normal work or school setting. The test or survey procedures involve no identifying information, not possible to link data to specific subjects. Disclosure would pose no risk of civil or criminal liability. Disclosure could not result in loss of financial status, employability, or reputation. Using existing data, documents, or specimens where no identifying information could link that data to subjects, so archival data, and use of educational tests and cognitive tests, such as aptitude, and and achievement measures. So that's the exempt. So the research, if it falls in the exempt, even if the research qualifies for exempt status, informed consent is still required by IRBs. If research results will be published or presented in a public forum, they can go ahead and start their research. The second category is expedited, which has minimal risk. So the exempt has no risk, and this has, if the proposal falls under expedited, it has minimal risk. Minimal risks, no more than minimum. The research is a type shown to pose no more than minimal risk. It's just minimal risk to subjects, and the protocol conforms to standard protocols commonly accepted for this type of study, identical to earlier approved studies. So it's something identical to another study that has been approved before. And the research represents just a minor modification of a research that has been done before, with a previously approved protocol, with all safety provisions for the protection of human subjects fully intact. So it's virtually identical to earlier approved studies. And the last category, the proposal can go under full review, which has more than minimal risk, and it involves the potential for more than minimal risk, and the methods, techniques, and treatments are largely experimental. The risk level is determined by the IRB. It's their responsibility to determine the risk level of that proposal, and not the researcher, because the IRB, they are the ones to review it. Full review will require the greatest degree of documentation, and such reviews will typically require considerably long periods of review, discussion, and deliberation before approval is granted. So they will take a lot of time to review this kind of proposal. So there are special subjects in researches, and these require careful planning. Special subjects such as therapist, client, or physician, patient, teacher and students, employers, employees, children, the elderly, anyone suspected of diminished capacity. And coming to the end of this presentation. So here the faculty just mentioned some things to consider and stories. About like 16 PF and lying. These are like the personality factor, cheating and stealing from students, making participation in a study part of the grading process. So these are just stories. And what is the age of majority in Turkey? Is this a concern yet? How will an IRB impact the rate, quality, quantity, or progress of research? How do we model ethical behavior in our discipline and research efforts? How will my colleagues react to peer review of research proposals? Coping with egos and avoiding adversarial confrontations, overcoming the US against them mentality. And that's it, coming to the end, concluding. I am open for any questions. I hope this was informative. Thank you.
Thank you so much, Rowan. Thank you, Rowan. It got a little dark there in the middle, Rowan, but thank you. With all the history and the way they used to do studies, we came a long way, definitely.
Yeah, yeah.
No, that was great. Thank you so much. All right, so next up on the agenda, we do have Dr. Ibtisam Ibrahim will be presenting a topic about all the applications that we need to use in our PGY 1 year. I'm assuming Dr. Nadir, he believes that we're all matched next year, so we know those applications. So fingers crossed, everyone. Dr. Ibtisam, you may begin.
Before you jump in, Dr.
Go ahead.
I just want to say that great presentation, and it's important to know the basics of the IRB. When I started my process of research here in the US, I thought, or the environment was that the IRB process is tedious, is difficult, it's just some hurdle or a wall against you by some of the researchers. But I found that if you work with the team of the IRB approval process reviewers, I think they are very, very helpful in terms of directing you to completing the required items and documents. And so it's a process where you really need to be focusing, understanding what's your method of the project of the research, and clarify things for them so that the end goal is to protect humans. And if you put yourself as a participant, you want to be protected. So I'm gonna just share with you a couple of things that I did in the past week with IRB. So I had 3 studies, but I'm gonna share 2 of them. One of them is here. This is about electronic portal usage in recovered older COVID-19 patients. So my question for this study is, when patients admitted to the hospital, at the end they will be discharged if they are feeling better home. So when they discharge them from the hospital here at Spero, they give them an access to a portal where they can access their lab work, x-rays, or any education materials, etc. So the portal itself, it's like the app you use in your computer or your phone. So they give them this information, how to log in, how to use password, and so forth. So my question is, how many of the patients who were discharged and they have COVID at the hospital, how many of them use that capability or that tool? So my thinking is we're gonna go review the chart and see how many use the tool. So this is the proposal of the, so I did the study form, the basic study information. So they ask about the title, the short title, description of what you want to do. And then there are other about 10 in total questions. So what kind of study is this? What do you want to do with the IRB? Is there an external IRB you want faster approval, or event? Who is running the show here? And then does there have financial interest? Am I benefiting from this in some financial positive way? And also the activity with the systematic investigation, including research development, testing, evaluation of just designing to develop contributor generalizable knowledge. So all these questions, they can be answered according to what's your study and your design of the study. And then this an important question is, does this actually involve living individuals? Because some of the studies include patients who died, or include animals or something. So this, for me, I'm looking for living individuals who were discharged from the hospital. So I will answer yes. It is sometimes some of the let's say residency or medical schools, they want you to conduct some research. So this question is this project being conducted to fulfill your requirement for educational training program, like residency, for example? And then there are some documents that you need to upload as far as what the study look like, some details, and some protocols, like these are the templates that they give you. So all these templates, they have some questions. If you log in similar to this, your answer, it will be clear to them. So let's say I submitted this information, edit, and then when I hit submit, it will go to the pre-review. So by that, they mean they will review and make sure everything is answered correctly and every document needed is uploaded and verified before it goes to the IRB board. So there are some, let's say, secretaries or some people who will review the study protocol. So in my case, in this study, they gave me feedback. So they want me to verify that I'm answering question number 1, number 2, number 3 correctly, because at the first time when I submitted, I did not answer this correctly. So they want me to do that. And then they want me to use this form document. So I did that. My next step is to submit this again to the review again, pre-review. So when I complete all the answers and upload all the documents, then I will submit it and it will go here again. They will review again and make sure every document is required is there and all the answers make sense. Then they will deliver that to the IRB board. Then it will take some time for the board to look at it and then say, oh yeah, or no, or maybe they need more clarification or some modification. So I do the modification and then at the end they will approve. So this is the study number 1. So I'm still in the process of getting documents uploaded and some answers corrected. So I did that and we're gonna wait for them to process. In the other study, this is about social media as an educational tool for the nursing home staff during COVID pandemic. So my question here, and this Akila and her team will be working on this project. So basically, we want to submit a questionnaire or a survey to the staff in nursing homes and see what kind of social media tools they use to obtain some information about, let's say, COVID or COVID vaccine. So this is the study the same way. So I put the title, the short brief description. This is the questions and answers I added, and some of the documents that they needed. So I uploaded the questionnaire, the abstract about what we're gonna do, and some of the content document and the protocol for what's gonna be done. And this is it's gonna be a faster study. So I think they asked me a quick question and they want me to upload a document. So I did that and it went faster than I thought it will take. And now it's approved. So if you go here, it can be review completed. And I got the email that this study has been approved, basically. So this is the way how at least here in at MSU, Michigan State, they do the things. They want you to complete the application for the study and upload every document that's required. They're gonna make sure everything is okay. If not, they will send you clarification. Then you clarify things and it will go when it's completed to the IRB board. And then the board will decide if they need more information, clarification or modification, then it will go here. And then finally, hopefully it will be approved and we're gonna start your study. So hopefully this will help you guys in the future as far as how we do things here. Thank you.
Thank you. Thank you so much, Dr. Nader. Thank you. That was very informative.
Thanks.
Thank you. All right, Ibtisam, you can go ahead and start.
Okay. Let me share my screen first. Hello, everyone. Hello, Dr. Nader. Good evening.
Hello, go ahead.
Today I'm going to present an apps that are used by the interns. First, sorry. We have up-to-date app. It is the most popular and famous one, and it's particularly useful for an overview of the pathophysiology, epidemiology, and common symptoms that are evident during physical examination and verify medication for patient. If hospital or institution is subscribed on up-to-date, intern will be able to have a personal up-to-date account on their iPhone or Android device or even a computer. Then also we have Lexicon app. It's drug reference app, but its disadvantage is that it's not free. It needs a subscription. It's quite pricey. It's probably the best and most common comprehensive drug reference app that provides clear and concise medication information, including dosing, administration, warning, precaution, as well as high quality clinical content. However, Lexicon requires subscriptions that range from 175 to 7,098 annually, depending on the package chosen. New users can register and access all the app database for free during the 30-day period. Although it may seem pricey, especially to new intern, Lexicon is worth every penny, because it's basically whole medical school placed in an app. The app is available also for Android and iPhone. Also, we have Read by QX Med app. This app is for literature. As for medical literature, journals, studies, and clinical cases at their fingertips is something that could help them greatly. Read by QX Med is one of the most popular apps that helps medical professionals keep up with new articles from various medical journals and tracks their continuing medical education credits. The most important thing, it is free. Intern can download it and install the app on both Android or an iOS devices. We have MedCalc. This is for calculation. This is the most popular tool for medical calculation and clinical decision support among the providers. Example for the calculation, like the burn area of lines, decorated calcium, curve 65 score, that of pneumonia, and we have also the chat bask and etc. It is a multifunctional tool that combines medical calculator and algorithm with well-referenced and evidence-based expert content, which all make it a must have for any physician looking for a great clinical decision support for different specialties. MedCalc is available also for iOS and Android. Also, we have GN Challenge app. The JAMA network developed a GN Challenge app that all intern and resident may use to test and improve their diagnostic and management skills by using their peer-reviewed case reports and images from across the JAMA network. GN Challenge app covers many specialties, including cardiovascular, medicine, dermatology, surgery, and more. Also available for Android and iOS app. Phones, I mean. We have eponyms app. Eponyms medical science are names given to diseases, clinical finding, and anatomical structure that can be used to summarize or communicate a complex abnormality or injury with your peers. Eponyms app is a comprehensive database of more than 1,700 entries that could help medical intern and residents learn more about common and obscure medical eponyms. The lack of detailed information and reference link doesn't make it particularly useful as a point of care tool, but rather a handy reference guide. Also available and free for iOS and Android. We have a clinical skill app. It's one of such app designed for clinicians, allowing them to quickly record and track their clinical skills and keep an accurate record of their airway and skills. Intervention on primary care or ER shift. Primary care residents can resort to other solutions which are available as web-based or mobile apps that could help track resident evaluation procedures as well as competencies and milestones. Also free for Android and iOS. Last, we have Guideline Central app. Is a clinical practice guideline to provide to providers mobile devices. This useful tool for daily clinical practice is available for free on both Android and iOS, and provide access to more than 2,600 guidelines indexed by organization, profession, specialty, and categories from more than 3 well-known medical associations. And this is the last one. Actually, I asked the residents who are in BGY 1 and 2, they only knows up to date. They don't know about the others. Thank you.
Thank you, Rowan. Thank you, Ibtisam. I think it's probably because up-to-date is provided for free. Maybe that's why.
Yeah.
No, those I think those also are free.
Oh, the other ones as well. Yeah.
Yeah. Only that what called lexicon. Yeah. But I don't know.
Oh, thank you so much. There were also a couple that Dr. Nadir put on the app. They're called like eMurmur, and one's called Litman Learning. I actually like both of these because like they teach you all about the heart sounds and the lung sounds. It's stuff that we honestly, like somebody like me who has not been practicing for a while, I kind of forgot all about those. So they would be pretty handy, I'm sure, for a lot of us.
Yeah.
Yeah, and they're you have to pay for them, but still, they are kind of useful. Thank you so much, Ibtisam. Thank you for that. That was very useful as well. Thank you. Dr. Nadir, do you have any comments?
Thank you so much. So this is also a great presentation. Thank you, Dr. Ibtisam, for the concise, to the point applications that can be used or tools that can be used. In the early days, when I started residency, we used to have like either pages or books, small booklets that you carry around. Some of them for, let's say, the antibiotics common that are used or medications that are used, but now with the apps, it's easier. And I agree with you, up to date, they have a lot of information, and they are basically the topics that cover what you need for your patients at the point of care. So if you are in residency, you have a question, you can get the answer right away comprehensively with using up to date. And most of the programs, they have prescriptions, so you already have free access to that. The other thing I want to share with you is that when you hopefully soon start your residency, most, if not all of the residencies, they have access to library. And librarian will be there, and their main job is to help you guys. So if you have questions, you didn't figure out the answer, or maybe you need more articles or more references, then the easy way to just submit that question to the librarian, and they will look it up. They collect all the information up to date. What they do, they collect the information in one place, so that person in the library will collect all the relevant up to date recent topic about your question, and it's like at the background when you see your patient. Next day you'll get all this information. You can just read about them. And the same question will be if you want to work on research proposal or project. Then you have the idea. You want to get some references. Then the library person can help you get some information. The last point, as far as murmurs and some sounds, UFM, University of Michigan, on their website, they have also some educational material regarding the murmurs, some cases with some murmurs that are also useful. So we can talk about it. Thank you so much. Yeah.
Thank you for your comments, Dr. Nader. Thank you. Next up, we do have Dr. Naod. He will show us how to do graphs on Canva. I know something that we all struggle with. So lead the way, Dr. Naod.
Everyone, can you hear me?
Yes.
Can you hear me?
Yes,
Yes.
we can hear you.
Okay, I'm trying to share my screen. So, okay, before we just immediately proceed to the technicality of the doing of the graph, I'm just going to show you 3 slides of how to use graphs and why do we need graphs. So the first question we should answer is, why do we need graphs? Number 1 is clarity, in which the message conveyed is easily understood by the recipient or by the participants in which you are presenting to. So when you present using graphs, you have clarity of what kind of message you are trying to convey to your audience. Number 2 is precision or more accurate. So when you present, let's say in a graph of 3 or 4 parameters of any form of finding, the way you are presenting is more precise instead of writing 7 or 8 lines in one slide. So it will give you another advantage of precision. And number 3 is it keeps your audience alert. If you come up to any form of presentation with 50 slides, and if all of your slides are written in words only, the chances that your audience are alert is less. So when you use graph, there is a tendency of people to have more focus on your presentation. And number 4 is when you present brief ideas. So I don't know if you are aware, nowadays, most of the time, let's say hypothetically, if one of our group from this research group come up with a new drug for any form of medicine, when you are presenting to your colleagues or experts like you, your ideas have to be brief. You don't have to go through pharmacology, pharmacokinetics, or the detailed explanation of what you are presenting. You try to do that in a research paper. But when you are presenting, the whole objective is to convey brief, quick, and accurate ideas. So when you do graph, this gives you an advantage of doing so. Number 5 is if you are a fluent speaker and have a good memory. If you are a fluent speaker and have a good memory, you can come up to a presentation which consists about which can go for about 1 hour, probably with 5 or 6 slides consisting of graphs and pictures. So you know the content, all you gotta do is how to incorporate whatever you have read or analyzed in terms of easily presentable form. And the 6th one is emphasis of content, especially pharmacological trials. You should at least include graphs because drug dosage, concentration, timeline, prognosis, failure, and all other parameters are best suitably presented in the form of a graph. And the 7th one is data and research presentation or algorithm. Whenever you hear the word algorithm, this way or that way, a graph should be incorporated into your paper. The last one, which is the scope of this group, is also publication. So if you propose any form of research paper to any journal, if you have a graph in your research paper, this will increase your polarity of your content, and the chances of your paper being published is really high. So this is why we all need at least know how to do graphs and how to best be equipped to deal with graphs and how to create graphs. And the last one is who needs this graph. So when you prepare a graph, your audience really matters. For example, if I am going to present, let's say, a simple example of SLA in women, I suppose you know that most of you have an idea about what SLA is, what are the drugs, what are the complications. So you are considered expert. So whatever graph that I am going to present to you have to be a more advanced graph rather than a graph that I'm going to present to a layman or people who are not in medicine. So when people are out of your scope, try to make the graph easily understandable and easily presentable and easily grasped by your audience. But when you are trying to present to your expert colleagues, because you are also part of the evaluation, try to include graphs which would also, pronounce or give a good idea of what you have done in your research or whatever medical specialty were involved. The second one is receptive and executive personals. Executive personals are people who are your immediate superiors, your boss. So when you propose or present a graph to them, at the end of the day, the outcome is determined by whether whatever you are proposing is better than what has been done before. So when you are presenting to your executive personals, you have to have numerically based graph showing that whatever you do or whatever you propose will increase the likelihood of, an example, pharmacological trial or project management or value of the company that you are presenting. When you are trying to present it to receptive people, for example, if you have a new drug, but when you are trying to present it to a population of 1 million, try to be less aggressive and less complicated as compared to other people. So this is why we need to do graphs. And when you do graph, try to incorporate these concepts into your head when you start preparing graphs, so that you will be more understood by your audience. So today I'm going to briefly go how to go into the Canvas graph. So you just go to Google, you click on Canvas graph. It will give you, the first one is Graph Maker, create an online charts and diagram in minutes. And you do have an option of logging in if you are a previous user, or you can also sign up if you are a new one. I think this is a technicality issue. Most of you are equipped or at least have an idea of how to sign up or how to log in. So with the brief time we have, I'm going to focus on create my graph now. The other one, by the way, the same. The only difference is just you have to go in, log in with your account, and you will have the same platform, and you will have a different graph formality that you can choose. So I will go in with saying create my graph. So if you are a new user, you can say help me go or help me choose a graph type. And if I had an idea before now on how to make graph, you say I know what graph I need. So let's start with this one. Help me choose a graph type. Then you will have a specific subcategories. So if you are trying to compare, if you are trying to show trends, or if you are trying to show composition and proposition, or if you are trying to present a form of relationship between 3 or 4 parameters, or if you are trying to prepare a schematic presentation of a project management or organizers. So usually, because most of us are involved in medicine, let's try to do one trend graph. So in the trend graph, you have a bar graph, the Gantt graph, and the line graph. Because the bar graph is already included in the other choice, we will go back and use the bar graph in the other choice button. So we will say line graph. So you will be given a different form of graphs to prepare here. So let's choose this one, line graphs. So when you click on this, you will have already prepared graph. So I can click here and delete, or maybe, give me 1 second. So in this graph, we have 2016, 2017, 2018, 2019, 2020. Let's say we want to prepare this graph on the form of coronavirus. And let's say in 2016, there were, let's say, 1 million. This is patients. And in 2017, let's say 2 million, just for technicality purpose. And let's say 3 million here. Let's say 4 million. And let's say here 5 million. Okay. So as you can see, this graph shows in 2016 we have 1 million, 2 million, 3 million, 4 million, 5 million disease patients. And you have a text here in this side. You can delete that one, sorry, and insert a text of your preference. Let's say here, population based in the US or population based outside the US. And in the heading, the one I deleted, you can include coronavirus by year or coronavirus by population. So after you are done with the graph, you can either present it right away. You can share it with other people using different sharing modalities. You can give them an access, you can give your friends an access to the presentation, and they can have an access to the graph, or you can copy link, and you have a different forms here. Let's say you can include other forms of app, such as photos, styles. So in the photo section, you can click photo and probably search a coronavirus from a pathology or from a microscopic picture, and you can incorporate it here. Text, you can include whatever text you want. So let's say you can click here and the lead is a coronavirus. In the US, let's say. The same application can be applied in this side of the graph, and you can include whatever small description or explanation you want in here. This is the text part. The up part is you can include graph, picture, different form of internet search memes you can be included here, and the other designs you can also change whatever design you want. So after doing this, you can either directly present it as a standard form of presentation like here, or you can share it with your friends so that they will have the same content when you present it online or outside your circles. So this was the one form of graph that you were aware of using. Let's check the other form, the one which you are aware of whatever graph you want to choose for presentation. So you click say, I know what graph I need. So when you know what graph you need, you will be given different form of graphs. And these are the different form of graphs. Most of them we are aware. The most commonly used graphs I have seen is bar graph, comparison chart, the bubble plot, the pie graph, the cycle diagram. For example, this one is usually used in genetics and biochemistry as a form of autosomal recessive or autosomal dominant. This Venn diagram can be used in goal search or in forming intersection between 3 or 4 parameters. Where do they lie in? Where do they combine in? So we will do, because we have short period of time, we will do one from the bar graph, which is usually used. Let's say we choose the first one. So we have it says animal kingdom here. Sorry. Can you hear me, guys?
Yes, sorry about that.
Yeah, we can hear you now. You're good.
Okay. So, okay, let's say this is the Telegeriatric Research Fellowship, and we want to introduce text. Maybe we can click here. So in this Telegeriatric Research Fellowship, this graph is going to explain on briefly one form of presentation in this group. So we can say in this gravity, let's say USMLE step 1 takers here. You can include USMLE step 2 takers, step 3, and step 4. So when you do that, it will show like how many of us are only taking USMLE in part of the TGF, the Telegeriatric Research Fellowship, and how many of them are already have taken their step 2, how many of them have already taken their step 3 and part of this group, and how many part of this group are already mature residents. So when you present it, it will be like a simple form, like out of us, let's say this parameter can be changed. 10 of the people have done step 1, 20 of them have step 2, let's say 50 of them have step 3, and let's say 50 or 70 of them have already done the 3 steps and have already matched the residency, but they are still part of the Telegeriatric Research Fellowship. And here in this content, you may include like Telegeriatric Research Fellowship is a fellowship which is suited to include anyway, it's like a form of explanation of whatever graph you are presenting here. And as the previous one, you can share, you can directly click the content, and you can directly present the content to your followers. I want to do the last one, the variety of doing graph. Just give me 1 second. The last one I want to do is a flow chart, which is also usually used by different people. So in this flow chart, I hope you are also taking the concept that when you try to present in a graph, you are probably saving up to 5 slides. So you are saving time, energy, plus when you present your colleagues, it's very easy and it will be easily transferable the information to your colleagues. So at the end of the day, what kind of presentation you make is judged by how attentive your audience are. So if your audience are attentive, they will be more likely to listen to you. So let's say, for example, for this one, let's say when to apply for residency. And in this, have you, we will change this text saying that, have you taken your step 1? The answer is yes. Are you applying this year? No. And the reason is because you didn't do step 2, let's say. So if you have you taken step 1, yes. Have you taken step 2? And you can include like what kind of parameters or what kind of research paper presentation you have done here. And if the answer is yes, then you can apply for residency. If the answer is no, then you cannot apply to residency. So when I do this, whatever information that I was trying to convey to you probably will take me 7 to 10 slides saying that the SML step 1 is like this, step 2 is this, step 3 is this, the SFMG and the ERAS require you to do this. But in one graph, I can simply put 2 or 3 sentences here, here, and here, and then it will be more easily conveyed to your audience. When you do that, you can share it, or you can click it, or you can present it right away. So this is like the whole concept of the Canvas graph. You can also, for example, have logged in using my Google account. You can log in and you can choose different format or template you use for your graphs. I hope this was helpful. This is the end of the presentation. Let me know if you have any form of question.
That was really amazing, Naod. That was pretty good. You definitely do have some teaching skills.
Yeah, I know. I wouldn't have done that. I would have no idea. Amazing.
That was very good. Dr. Nader, you have the floor.
Excellent. Thank you so much, Dr. Naod. This is also excellent tutorial or presentation, concise and informative. Hopefully, this will help you guys when you are presenting or you are doing your graphs or your whatever poster, and hopefully when you are doing your residency as well. So for the next topic, I'm going to share with you okay, let me share my screen here. So my topic will be about the race and racism. It's an ongoing topic, but in the recent days, in healthcare, they are focusing on equity, especially when COVID hit. So a big proportion of minorities, Black American and other minority groups were affected more compared to the white race groups. So here we will talk a little bit about that, but it's a big topic. So I chose that because Dr. More, Larry is one of the neurologists here at MSU. He's the director of the headache and special pain division. So he did present, I think, one of the grand rounds of neurology a few weeks ago, and he was talking about this, and they published an article. That article was, this is just abstract of it, Black patients matter in neurology. So their focus was just Blacks in neurology. They did their study. This is the whole article. I'm going to share with you this in the chat in a few seconds. But basically, it's published in the Journal of the American Academy of Neurology, which is a big deal. So they talk about how they did their study and then how they present that in readable format. It did not go through the same way we used to write our manuscript. So he talked about disparity in research and clinical, and with some data to support these points. And he's focusing on the neurologists, how they can deal with this, how they can fix this problem in different practices. So this is an important topic in the area of neurology, for example. So the topic itself can be described by healthcare disparities. This is a short presentation that was also available online that you can also basically go over the definition, some of the disparities, what people are doing, how we can identify the determinant of health and how we can combat or fix these problems. Hopefully, the minorities will be hopefully help to face any challenges, including any pandemic in the future, for example. So this is the topic I wanted to share with you guys. I'm gonna share this video in the chat. This is the article. This is the presentation. So whenever you have a minute, maybe you can look at the presentation, see what people are doing, and then you can read the article about race and actually black patient matter in neurology. The other point I want to share with you, can I just stop sharing, is that as you can see from what I shared with you, in research, you don't have to really stick to what in like the topics or the ideas that we want to do this, and we want to study coronavirus and the effect of pulse, depression, and something like what we get in medicine. But you can go back and look at what's happening in real life, like this doctor. He looked at what's going on with black patients in neurology. So maybe if you are interested in seeing in children, if you are interested in applying to pediatric, for example, you can apply the same concept. You can do a similar study. You can write a similar article, black patients, minor or in children or something in neurology, for example, or in whatever area that you are interested in, and you can start a group with you who are sharing the same interest, and you can start that project. It's doable. Sometimes you can just look back, look at the literature, or you can get a survey. You can look at what's going on from patients, from residents, or program directors and staff, faculty. So there are many options that you can do as far as getting new ideas from what's published. So I'm sharing this as an example that you can read some articles and create some new concepts or ideas, and then investigate as far as how we can apply the same concept but in a different population or different group or different target participants. Thank you. Any questions? Let me know.
Thank you, Dr. Nader. I don't have a question, but I do have just one comment. I do remember there was a doctor, Dr. Joel Berville, I believe that's his name. He's a fourth-year med student, and he was doing a study out of Johns Hopkins. It was about COVID and African American individuals, and they found out that the reason why not the reason why per se, but one of the reasons why a lot of African Americans died during COVID is that they were using a pulse ox, and it doesn't read as well in people of color versus Caucasians. So every time they use it on somebody who's African American, it reads like 98, but in reality, it could be like 89 or 90, and they're just not paying attention, don't have that in mind. So sadly, a lot of patients did die because of that. Yeah.
Sure. Yeah, so there are some areas for you to get more ideas, as you mentioned. Medical students or graduates or residents, they can come up with some ideas. And we are here to help you. If you have some idea, we can direct you or help you get growth in place and then resources so that you can complete the task of that project. Thank you for sharing. Anyone else wants to share or questions? If no questions or comments, we can move on to the next topic. The updates. Anyone wants to share? Please raise your hand for compliment. Go ahead, share your ideas or updates as far as your projects. I know we submitted, I think, 5 abstracts to AMDA. And so far, I think we got 2 rejections or not accepted. 2 abstracts were not accepted. So we can notify them and see if we can submit them to some other places. So Nafisa, do you have any update about the process? Go ahead, Ahmed. Dr. Ahmed.
Hello, Dr. Naod. Good evening.
Good evening.
So I have new updates regarding the INR app. Since this application was primarily created for the elderly, we decided to add a new button in the educational section of the app. The function of this button is to read text aloud for patients who cannot read clearly due to vision problems, for example. So I recorded each text using an application that converts text to voices in the standard English American accent. Then I uploaded them into my YouTube channel and finally added them in the application. So I hope that looks great. I'm not sure.
Excellent.
I'm waiting for my team feedback.
Excellent. Do you have a minute to show us how that works, or?
So should I share my screen?
If you have a minute.
Okay. Just a minute.
That's great. Great step, and I think it will
Thank you so much.
more sense to use it. And one idea, maybe you can help me with that. When we are doing similar project or research, we are required to involve some of the target population. Let's say if we are talking about older patients, maybe you can ask some of the available family members or your patients or your teachers, somewhere where they can give you some feedback. So by that we will see how they reflect on what else that they think might be added. As you mentioned, some as we get older, some may need reading glasses, or some may have issues with arthritis. So maybe we can solve some of these difficulties. Yeah, thank you.
Thank you, Dr. Naod. So for example, if I clicked in the first question, what is INR? So the patient might not be able to see the text. So then I add this button.
Excellent. I will only read or display the video. We lost your voice. Maybe the network.
Yeah, looks like a connection issue.
Yeah. But this is a great work. Go ahead. She can take another.
Dr. Nader, I'm sorry about that, but I'm not able to share due to a problem.
Yeah, that's fine. I think the app itself, the company, they have a little bit of issues with their servers. So, but thank you so much for sharing. I think we got the idea that with just hitting one button, that information can be displayed differently.
Yes.
Instead of reading, the video will show up and then someone will read for them. So I think that's a great feature. So we can talk about that when we produce the app, that some of the features include these features for the older patients. Excellent.
Thank you so much, Dr. Nader.
Thank you. Awesome. Anyone else wants to share their updates or ideas? We can open the floor for any questions in general. As far as this fellowship going, any modification that you need to do, anything that you think you want to learn and that you can focus on.
Dr. Nadir, I have a question actually.
Sure, yeah.
I heard from like a lot of the fellows that when they went to like residency interviews, they were asked about like the TGRF fellowship and what kind of fellowship it is and accreditation, all those questions. So if you could just tell us a little bit about that.
Okay.
Thank you so much.
Yeah, you're welcome. So basically, it's an idea of helping medical graduates to achieve their goals of attending or entering the residency. It's not accredited as of now. We are supported, or at one point we were supported by the Federal Outreach Award or funding for the first 2 years. Now we are seeking different funding opportunities. The goal is to start the basics of research. So some of you might have advanced ideas, but some might have little or no research experience. So we start from the basics and build up on these experience or skills, so that by the time you finish the fellowship, at least you have a very good idea about if you want to start a project, what kind of steps you need to put in place, how you can build your team, how can you organize the task and identify who will do what, and then complete this task. So in the form of a project, a research project. So you can bring an idea, you can develop that, or you can jump into a team where the team already started, and then you can be part of that team. So you complete little task, but the whole team will finish this project in time. But the topics of the projects are different aspects or areas, but we focus on the geriatric. It's not limited to geriatric, so we have some of your interest in neurology, for example, psych, or pediatric, for example, some pathology. So you can identify the area where you want to go ahead with your residency and future career. So you can focus on that area, or you can do any other part of the other topics. But the goal is to get the skills of doing a research from start to end. If you know that, I think that will be greatly appreciated when you start your residency, because it's one of the requirements. At least you finish some projects, scholarly project during your residency. And if you are applying for fellowships, then the more the better. So the more projects or publications you finish, the more chances you will get as far as your higher or phase of education you want, or training. Like let's say you want to go to cardiology, you need to do a lot of research and publish in order to be a competitive candidate for certain programs. So this is one of the goals. The other one, including the character building. So we want to build new some of the skills as far as personal skills, like communication skills. So I want you to present. So by this, you will get the confidence on presenting to your colleagues. That will be required also in residency. I want to get you to know the basics of professionalism. This will be a useful tool when you are dealing with your seniors or when you're dealing with your juniors. The same goes with teaching skills. So if you are presenting, for example, some of you presented today, most likely you will do some homework, you will read about the topic, and then you will come up with some way of doing the presentation. And then when you teach, it's going to be a skill that you can improve on. So by the time you enter your residency, you will be required at one point to teach medical students, to teach your DPY when, and if you become a fellow, then you want to teach the whole team under you. When you are a physician, it goes without saying that you want to teach your patients. Sometimes you want to teach them about medication, about other things, side effects of the COVID era, about the vaccine and so forth. So if you collect all the tools or the skills of teaching, then it will be easier for you to communicate with your patients or your other team members, including medical students or residents under you. Other skills, teamwork skills, communication skills, presentation skills, and also how you can develop other extra skills like what Ahmed is doing. It's a new innovative approach of developing apps. This is technology. We were talking about artificial intelligence. So how can we think not only as physicians, but how can we use the technology available in order to be helpful to our patients and our education ourselves. So these all in general, I think help you to achieve your goal, the immediate goal to go into residency. But we are talking about 5 years from now, how you can look at this fellowship and say, oh yeah, I learned this, and now it's useful for me. And I'm glad I did this year. The limited year is 1 year, but you can stay as long as you can. The requirement is 1 project, at least within this year. We want you to finish 1 project. If you do more, the more the better. And if you want to be the team leader for the project, you'll be the project leader. When you publish, you may be the first author. Although at this level might not make a huge difference, but you will get the idea when you go to residency and fellowship. If you want to become the first author, you know how to do the stuff. You know how to identify team members and divide the task and organize everything like an orchestra. So you will be the team leader for that project, and you will be the first author if you want to. So this is a nutshell, basically.
Thank you so much, Dr. Nader. And I think I
You're
speak for
welcome.
everybody when I say we really do appreciate your time and efforts that you're
You're
putting in,
welcome anytime.
honestly. And a lot of us have learned so much about research and how to do like the research projects from the basics to like from A to Z. And in terms of presentation, I think when I presented here the first time, it was my first time presenting in about 6 years. So it has been like a hot minute since I presented the last time. So we really do appreciate it. Thank you so much.
You're welcome.
Of course.
Thank you. Glad to hear that. And life is busy, so every one of us has unique situation. So hopefully all of us will achieve our goal, and I wish you all will have the chance to start your residency, and hopefully you will come back and help us do the same for next generation.
Thank you. We'll make sure to pay it forward.
Yeah. Thanks. Any other questions or clarifications or ideas or suggestions or comments? Fellows, you have 5 minutes if you want to jump in or raise your hand. So for the next group, next meeting, it will be the purple team. We'll also continue with the cardiovascular call, and we'll go over some of these topics. So I hope that the team members will reach out to the team leader and discuss who will be able to present. I know some of you might be traveling, some of you might have other obligations, especially or other things in life. But if you are available and you are willing to participate, please communicate. If you are not able, also communicate with your team leader, because if you have a small number, some of the other fellows in the other teams, they may be available to help you guys and present next week. For the 2 weeks later, not this coming Saturday, then after that we will not have the meeting. So that team will be off the hook. I think the great team. So if the great team members are available to help the team, if there are not enough people ready, that would be appreciated. I'd like to thank all the presenters. You did great work. Thank you so much for moderating this Zoom meeting, and thanks for the fellows who attended today's meeting and those who will come and look at the recording later. Have a wonderful day. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you.
Thank you so much for your time, Dr. Nader.
You're welcome. Thank you.
Assalamu alaikum.
Assalamu alaikum.
Thank you, Dr. Nader.
Assalamu alaikum. Thank you. Thank you.
Thank you, Dr. Nader.
Thank you.
Dr. Nader, just before I go,
Yes.
we have a quick question about, like we do apologize for the late preparation in terms of the pink team. We did have some kind of miscommunication in the middle there, like about the leadership and who was it, and it was just a bit of a mess. We do apologize.
No, that's fine. That's fine. Part of it is on my side, so I want to make sure the teams are like working together, and whoever
Yes.
available, yeah. So who's the leader now for the team? Do we have someone?
I mean, I think I just took over today, honestly.
Sounds good.
So-
Sounds good. Yeah, that's a good thing.
Yeah.
Thank you so much. We appreciate your help. Yeah,
Of
I think
course,
it's a good opportunity. Yeah.
It definitely is. It definitely is. Yes, and we'll make sure to communicate better in the future.
No problem.
Thank you
Thank
so
you
much.
so much. Thank
Of
you.
course.
Wonderful.
Have a great
Yeah.
day. Enjoy the rest of your day. Bye.
You too. Thank you. Have a good day.
Thank you
Bye-bye.
so much.
You're welcome. Thank you. Thank you.